So, pharmacology of psychiatry, psychotherapy, behavioral therapy teaches patients how to identify and change maladaptive behaviors or reactions to stimuli. For example, systemic desensitization for specific phobia. Okay. Uh, Cognitive behavioral therapy teaches patients to recognize distortions in their thought processes, develop constructive coping skills, and decrease maladaptive coping behaviors. Greater emotional control and tolerance of distress, for example, recognizing triggers for alcohol consumption. So it teaches patients to recognize distortions in their thought processes. Okay. Uh, Dialectical behavior therapy, designed for use in borderline personality disorder, but can be used in other psychiatric conditions as well. For example, depression. Okay, so it's used for borderline, but it can be used for depression. Interpersonal therapy, focused on improving interpersonal relationships and communication skills. Motivational interviewing enhances intrinsic motivation to change by exploring and resolving ambivalence. Used in substance use disorder and weight loss. Okay, motivational interviewing. What's interpersonal therapy? It was focused on improving interpersonal relationships and communication skills. Okay. Supportive therapy utilizes empathy to help individuals during a time of hardship to maintain optimism or hope. Okay, so we all require that. Preferred medications for selected psychiatric conditions. Okay, and preferred drugs. So, for ADHD, it's stimulants, right? Because in ADHD, they crave stimulus. So the stimulants provide that stimulus, so then they don't get affected with the need to move around. Alcohol withdrawal, benzodiazepines. Okay, benzos for alcohol. Uh, Bipolar disorder here. Carbamazepine, atypical antipsychotics, lithium, the popular one, lamotrigine, valproate. Okay, uh, character a little less variable. Okay, so carbamazepine and atypical antipsychotics, lithium, lamotrigine, and valproate. Uh, Bulimia nervosa, SSRIs. Depression, also SSRI. So what does SSRI do? It's serotonin reuptake inhibitor. Okay. So it leaves the serotonin in the gap for longer time. Okay. And that can cause serotonin syndrome as well. Okay. Depression, SSRIs. Generalized anxiety disorder, SSRIs, and SNRIs. So in this SNRI, same thing, but with norepinephrine. Uh, Obsessive compulsive disorder, SSRIs, venlafaxine, and clomipramine. Okay, so that is also SNRI, and this is right. Let me check. SNRI. Yeah, SNRI. Okay. And clomipramine, panic disorder, SSRI, SNRI, which is venlafaxine, and benzos for panic attacks. Okay, or panic disorder. PTSD, same thing, SSRI and venlafaxine. But here you will have prazosin, the alpha, what was it, alpha agonist or alpha blocker, whatever that is. I think it's the blocker, prazosin. It's not going to be here, but anyways, um, for nightmares. Okay. Schizophrenia, atypical antipsychotics. Okay, and social anxiety disorder, SSRIs, venlafaxine. Performance only for the palpitations and all that, tremors, beta blockers, and benzos. And Tourette syndrome, antipsychotics. Okay, so Tourette's for the tics, we give antipsychotics. Okay, so central nervous system, methylphenidate, dextroamphetamine, methamphetamine, and lisdexamfetamine. Okay, mechanism increases catecholamines in the synaptic cleft. Okay, especially norepinephrine and dopamine. So clinical use is ADHD, narcolepsy, binge eating disorder. Adverse effect: nervousness, agitation, anxiety, insomnia, anorexia, tachycardia, hypertension, weight loss, tics, bruxism. Antipsychotics. Typical first generation antipsychotics are haloperidol, pimozid, trifluoperazine, flufenazine, thioridazine, chlorpromazine. Okay. Atypical second generation antipsychotics: aripiprazole, escitalopine, clozapine, olanzapine, quetiapine, iloperidone, paliperidone, risperidone, loracidone, and ziprasidone. Okay. So with antipsychotics, the mechanism is it blocks dopamine D2 receptors. Okay, so it increases CAMP. Atypical antipsychotics also block serotonin 5-HT2 receptors. Okay, and aripiprazole is a D2 partial agonist. Clinical feature here is, so we gotta know which ones are the typical and which ones are the atypical ones. So chlorpromazine is chlorpromazine, haloperidol, the popular ones, are typical antipsychotics, and atypical antipsychotics like risperidone, ziprasidone, clozapine, these are, and olanzapine. Okay, so these are antipsychotics, atypical ones. Clinical use: schizophrenia. Typical antipsychotics primarily treat positive symptoms. Atypical antipsychotics treat both positive and negative symptoms. Okay, disorders with concomitant psychosis, for example, bipolar disorder, Tourette syndrome, OCD, Huntington disease. Clozapine is used for treatment-resistant psychotic disorders or those with persistent suicidality, close to the age. Okay, so clozapine for that. Adverse effects: antihistaminic sedations, anti-alpha-1 adrenergic, orthostatic hypotension, antimuscarinic, dry mouth. Okay, constipation, anti-ham. Okay, so antihistaminic sedation. Okay, anti-alpha-1 adrenergic, orthostatic hypotension, antimuscarinic, dry mouth, constipation. Use with caution in dementia. Metabolic: weight gain. So antipsychotics will cause metabolic symptoms as well. Weight gain, hyperglycemia, dyslipidemia. Highest risk with clozapine and olanzapine. Okay, remember that one. Endocrine: hyperprolactinemia, galactorrhea, oligomenorrhea, gynecomastia. Cardiac: QT prolongation. Okay, neurologic: neuroleptic malignant syndrome. That's an important one. Okay, remember the mnemonic for it? I was malignant fever. M for something something something. Anyways. Okay, so that ophthalmologic chlorpromazine. Hold on, let me go grab this real quick. Alright, so this was the mnemonic: malignant fever. M for myoglobinuria, F for fever, E for encephalopathy, V for vitals unstable, E for increase in enzymes like CK, and R for muscle rigidity like lead pipe. Okay. Ophthalmologic, chlorpromazine, corneal deposits, and thioridazine will cause retinal deposits as well. Okay, so thio is for retinol and chlor is for corneal deposits. Okay. Clozapine, agranulocytosis. That's important. So neutropenia is the one you would pick if they give you a bunch of options, which one it causes. Then it's neutropenia for clozapine. Monitor WBCs closely. Okay. Seizures, dose-related myocarditis. Okay. Extrapyramidal symptoms, adapt. Okay. Hours to days, acute dystonia. Okay. This is muscle spasm, stiffness, oculogyric crisis. Treatment, benztropine, diphenhydramine. Days 2 months, akathisia, restlessness. Treatment, beta blockers, benztropine and benzodiazepine. Parkinsonism, bradykinesia. Treatment, benztropine, amantadine. Months 2 years, tardive dyskinesia, chorea, especially orofacial. Treatment, benzodiazepines, botulinum toxin injections, valbenazine, deutetrabenazine. Okay. Notes: lipid soluble, stored in body fat, slow to be removed from body. Typical antipsychotics have greater affinity for D2 receptors than atypical antipsychotics. Increased risk for hyperprolactinemia, extrapyramidal symptoms, neuroleptic malignant syndrome. High potency typical antipsychotics, haloperidol, trifluoperazine, pimozide, and flufenazine. Hull tries pi to fly high. Okay. More neurologic adverse effects. So these will cause more neurologic adverse effects like extrapyramidal symptoms. Low potency typical antipsychotics like chlorpromazine and thioridazine. That's cheating thieves are low. Okay, cheating thieves are low. More antihistaminic, anti-alpha 1 adrenergic, anti-muscarinic effects. Okay. Lithium affects neurotransmission, decreases excitatory and increases inhibitory and second messenger systems like G proteins. Okay. Clinical use, mood stabilizers for bipolar disorder, treats acute manic episodes and prevents relapse. Okay. Okay, so treats acute manic episodes and prevents relapse. Adverse effects of lithium, there are a bunch. Tremors, hypothyroidism, hyperthyroidism, mild hypercalcemia. Polyuria causes nephrogenic diabetes insipidus. Teratogenesis causes Epstein anomaly. Narrow therapeutic window requires close monitoring of serum levels, almost exclusively excreted by kidneys. Most is reabsorbed at PCT via sodium channels. Thiazides, ACE inhibitors, NSAIDs, and other drugs affecting clearance are implicated in lithium toxicity. Lithium, okay, so almost exclusively excreted by kidneys. Most is reabsorbed by PCT via sodium channels. Thiazide, ACE inhibitor, NSAIDs, and other drugs affecting clearance are implicated. So you gotta look out for those as well. Okay, and lithium toxicity. Lithium, low thyroid. H for heart, Epstein anomaly. I for insipidus, nephrogenic diabetes insipidus. Because it causes ADH resistance. Okay, and unwanted movements, so tremor. Okay, unwanted movements, insipidus, heart, and low thyroid. Buspirone, mechanism, partial 5-HT1A receptor agonist. Okay, so you can remember it as I get anxious if the bus doesn't arrive at 1, so I take Buspirone. So this is taken for generalized anxiety disorder. Does not cause sedation, addiction, or tolerance. Begins to take effect after 1 to 2 weeks. Does not interact with alcohol versus barbiturates and benzodiazepines. Okay, so I get anxious if the bus doesn't arrive at 1, so I take bus 1. Buspirone. Okay. Antidepressants, SNRIs and SSRIs. So how does it work? So SSRIs, what does it do? It prevents reuptake of SSRI. Serotonin, which I don't see here represented. Well, 5-HT reuptake, so I guess that. Okay. So we have Mao going in, going out to this, TCAs, SNRIs, bupropion, inhibiting reuptake of NE, alpha 2 adrenergic receptors, so mirtazapine will inhibit that, and this in turn will inhibit the release of NE. And yeah, that's about it going on. So SSRI, selective serotonin reuptake inhibitor, fluoxetine, fluoxamine, paroxetine, sertraline, escitalopram, and citalopram. Okay, so the mechanism is it inhibits 5-HT reuptake. Okay, right there. Clinical use: depression, generalized anxiety disorder, panic disorder, OCD, bulimia, binge eating disorder, social anxiety disorder, PTSD, premature ejaculation, premenstrual dysphoric disorder. Adverse effects: fewer than TCAs, serotonin syndrome, GI distress, SIAD, sexual dysfunction, anorgasmia, erectile dysfunction, decrease in libido, mania precipitation if underlying bipolar disorders. Okay. So it normally takes 4 to 8 weeks for antidepressants to show appreciable effect. Okay. SNRI, venlafaxine, aldafaxines, and zetine and prans. Okay, so zetine, vaccine. Okay, venlafaxine, desvenlafaxine, duloxetine, and levomelanocipran and melanocipran. Okay, mechanism: inhibit 5-HT and NE reuptake. Clinical use: depression, generalized anxiety disorder, diabetic neuropathy. Venlafaxine is also indicated for social anxiety disorder, panic disorder, PTSD, OCD. Duloxetine and melanocipran are also indicated for fibromyalgia. Adverse effects: increase in blood pressure, stimulant effects, sedation, sexual dysfunction, and nausea. Okay, so it works on both SNRI. Okay, 5-HT and NE. And duloxetine and melanocipran are also indicated in fibromyalgia. So venlafaxine is also indicated for social anxiety disorder, panic disorder, PTSD, and OCD. Okay, and all the rest of them: depression, GAD, and diabetic neuropathy. Adverse effects: increase in blood pressure, stimulants effects, sedation, sexual dysfunction, nausea. TCAs or tricyclic antidepressants: amitriptyline, nortriptyline, imipramine, desipramine, clomipramine, doxepine, and amoxapine. Mechanism: TCAs inhibit 5-HT and NE reuptake. Okay, so it's similar to this, SNRI and that. Okay, so clinical use is for major depressive disorder, peripheral neuropathy, chronic neuropathic pain, migraine prophylaxis, OCD, clomipramine, and nocturnal enuresis imipramine. Okay. Water break. Adverse effects: sedations, alpha 1 blocking effect, including postural hypotension and atropine like anticholinergic. Adverse effects: tachycardia, urinary retention, dry mouth. Tertiary TCAs, amitriptyline, have more anticholinergic effects than secondary TCAs like nortriptyline. I guess. Can prolong QT interval. Okay. Tricyclics, CCCs, so convulsion, coma, and cardiotoxicity. Arrhythmia due to sodium channel inhibition. Also respiratory depression, hyperpyrexia, confusion, and hallucination are more common in older adults due to anticholinergic adverse effects. Secondary amines, for example, nortriptyline, better tolerated treatment, bicarbonate to prevent arrhythmias. Okay. Monoamine oxidase inhibitor, trenylcypromine, okay. Phenylazine, isocarboxide. That's a funny way to spell that. Isocarboxide. Seleglene, that's selective MAO-B inhibitor, and Mao takes pride in Shanghai. Okay. Yeah, not gonna remember that. Transilpromine, phenylazine, isocarbozide, and seleglene. Okay. Selegiline. Okay. Mechanism: non-selective MAO inhibition, increased levels of amine neurotransmitters, so norepinephrine, 5-HT, and dopamine. Clinical use: atypical depression, anxiety, Parkinson disease, selegiline for that. Okay. Or selegiline. Adverse effects: CNS stimulations. Okay, so CNS stimulation, hypertensive crisis, most notably with ingestion of tyramine, contraindicated with SSRIs, TCAs, St. John's wort, mepridine, dextromethorphan, pseudoephedrine, linezolid, to avoid precipitating serotonin syndrome. Wait 2 weeks after stopping MAO inhibitors before starting serotogenic drugs or stopping dietary restrictions. Atypical antidepressants, bupropione, inhibits NE and DA reuptake, also used for smoking cessation. Adverse effects: stimulant effect, tachycardia, insomnia, headache, seizures in patients with bulimia and anorexia nervosa. Decreased risk of sexual adverse effects and weight gain compared to other antidepressants. Okay, so bupropione, it reduces the risk of sexual adverse effects and weight gain compared to other antidepressants. Okay, so what does it do? It inhibits NE and DA reuptake, so there is more in the synaptic cleft. It's also used for smoking cessation. Adverse effect here is stimulant effect, tachycardia, insomnia, headache, seizures in patients with bulimia and anorexia nervosa. So we do not use bupropione for bulimia and anorexia nervosa. So gotta remember that. Mirtazapine, what is that? That's an alpha 2 antagonist. Okay, it increases release of NE and 5-HT, potent 5-HT2 and 5-HT3 receptor antagonist, and H1 antagonist as well. Adverse effect here is sedation, which may be desirable in depressed patients with insomnia, increased appetite, weight gain, which may be desirable in underweight patients, and dry mouth. Trazodone. Uh, Trazodone primarily blocks 5-HT2 alpha 1 adrenergic and H1 receptors. Also weakly inhibits 5-HT reuptake as well. Okay, so it's used for primarily for insomnia, as high doses are needed for antidepressant effects. Adverse effect: sedation, nausea, priapism, and postural hypotension. Think trazobone due to sedative and male-specific adverse effects. Okay, so trazobone is it increases risk of sexual adverse effects, whereas bupropion decreases risk of sexual adverse effects. Okay, and ZZZ for sedation. Vilazodone, okay, inhibits 5-HT reuptake, 5-HT1A receptor partial agonist, used for MDD. Adverse effects: headache, diarrhea, nausea, anticholinergic effects, may cause serotonin syndrome if taken with other serotogenic effects. Vortioxetine, it inhibits 5-HT reuptake and 5-HT1A receptor agonist and 5-HT3 receptor antagonist. Used for major depressive disorder. Adverse effects: nausea, sexual dysfunction, sleep disturbances, anticholinergic effects, may cause serotonin syndrome if taken with other serotogenic agents. Pharmacotherapies for smoking cessation. Nicotine replacement therapy binds to nicotinic acetylcholine receptors, aim to relieve withdrawal symptoms upon stopping smoking. Long-acting patch and short-acting products like gums and lozenge can be used in combination. Adverse effects: headache and oral irritation. Okay, so that nicotine replacement binds to nicotinic acetylcholine receptors. And then we have varenicline. That's the important one you gotta remember. Nicotinic acetylcholine receptor partial agonist, diminishes effect on reward system. Okay, but also reduces withdrawal. So adverse effect here is GI discomfort and sleep disturbances. Varenicline helps nicotine cravings decline. Okay. Okay, so Klein, if we pronounce it like that, then varenicline. So varenicline helps nicotine cravings decline. Okay, varenicline. Medically supervised opioid withdrawal and relapse prevention. Okay, so injection drug use increases risk for HBV, HCV, HIV, skin and soft tissue infections, bacteremia, right-sided infective endocarditis. Methadone, long-acting oral opioid used for medically supervised opioid. For example, heroin withdrawal or long-term maintenance therapy. Buprenorphine, partial opioid agonist, sublingual form film, used to suppress withdrawal and for maintenance therapy. Partial agonists can precipitate withdrawal symptoms in opioid-dependent individuals or when administered shortly after use of a full agonist. So, that naloxone, short-acting opioid antagonist given IM, IV, or a nasal spray to treat acute opioid overdose, particularly to reverse respiratory and CNS depression. And then you have naltrexone, long-acting oral opioid antagonist used after detoxification to prevent relapse. may help alcohol and nicotine cessation, weight loss. Use naltrexone for the long treks back to sobriety. Okay. So methadone, it's used for medically supervised opioid withdrawal or long-term maintenance therapy. Okay. Buprenorphine, that's partial opioid agonist. Okay. And it's used to suppress withdrawal and for maintenance therapy. Okay. It can precipitate withdrawal symptoms in opioid dependent individuals or when administered shortly after use of slow agonist. Okay, so these two are used for withdrawal symptoms. Okay, it's not used for intoxication of opioid. For intoxication, you use naloxone, okay, short-acting opioid antagonist given IM or IV, or a nasal spray to treat acute opioid overdose. Okay, particularly to reverse respiratory and CNS depression. And naltrexone is used to prevent relapse. Okay, so use naltrexone for long treks back to sobriety, and that's it for that.